Hello there everyone, and a very big warm welcome to this webinar on analgesic protocols for acute pain in cats. It's great to see so many of you joining us for what is going to be an absolutely fantastic session. Now, you will notice that there are a couple of tabs. These will either be to the right of your screen if you're on a laptop or computer, or below it if you're on a mobile device. If you click on the Resources tab, you will find a CPD certificate and a PDF of the slides. You can download those at any point, including after we finish the session today, so no rush to do it now. I've also added a link to the guidelines which are being covered tonight as well. We are aiming for a live Q&A session at the end of the presentation, so if you have any questions at all, please type them into the chat box. So if you scroll down, you'll see that at the bottom of your screen, and you can do that at any point. Lots of people saying hello at the moment, so hello to you all. You found the chat box already. That's fantastic. We are recording the session, so don't worry if you miss anything at all. You'll be able to come back and watch again very shortly after we finish today, and the notes and the certificate will also remain available alongside that recording. So again, no rush to have to do all those immediately now. You can sit back and enjoy. Now, we're bringing you this webinar free of charge as part of our Cat Care for Life program, which is very kindly sponsored by Boehringer Ingelheim. Cat Care for Life is an absolutely fantastic resource for veterinary clinics, but also for cat caregivers. There's a section for cat owners on there as well. And if you haven't already visited the website, then I would definitely encourage you to have a look to find out more. For veterinary clinics, there's a huge range of resources, and the best thing is it's all free of charge, totally free of charge. There's lots of things that you can download on there, so the lovely How Old Is Your Cat poster, which clients love, but also some great tools to use in the clinic, such as a blood pressure monitoring form, dental charts, mobility checklists, and much, much more. There's so many things on there that you can just download free of charge and use as and when you need to. So please do have a look when you get a chance, but maybe not now. That's something for later. Finally, just before we start, I'm going to put a very quick plug in for ISFM membership. If you enjoy this session, then if you become a vet member, you'll get an exclusive webinar every month, as well as being able to access the whole back catalogue of the ones that we've done over the years and some other fantastic benefits. But that's enough from me. Now over to what you are all here for and what you're waiting for. We are absolutely thrilled and delighted to have Dr. Paulo Stiegel present for us today. He's a professor of veterinary anesthesia and pain management and an absolutely fabulous speaker and presenter, as you will now find out. Here we go.
Hi, how are you? My name is Paulo Stiegel, and I'm a professor of veterinary anesthesia and pain management at City University of Hong Kong and University of Montreal. And I also happen to do quite a bit of research with these topics in cats. And I'm here today to talk about building optimal analgesic protocols with the 2022 ISFM acute pain management guidelines, which I had the opportunity to be the panel co-chair, and we're going to talk a little bit about that. But I would like to thank the ISFM for the invitation, and also for you for being here and being watching this. And I think it's going to be an interesting discussion, because I think I prepared something completely new from everything that I had it before. So let's talk about this. Before we actually get started, I would like to just to present you my disclosure slides in terms of my consultancy services, my key opinion leader activities, and where I also received speaker honoraria, as we're going to be talking about a lot about treatment today, including drug use and some products available in the market. So let me talk a little bit about the guidelines in general. I had the opportunity to co-chair this project with Dr. Sheila Robertson and an amazing group of co-authors, and also working with individuals from the ISFM, International Cat Care, and Journal of Feline Medicine Surgery, which I'm actually really proud of, because I think we are able to reach our aims and goals in the end of the day. a little bit of the background. So we worked for about a year on this project, just going back lots of emails and drafts and getting everyone together, discussing, coming to a consensus, because in the end of the day, there's a lot of evidence base there, but it's also related to a consensus among the authors and etc. It is very exciting because it's a kind of new product. There are tons of figures, videos, tables, doses, and so forth. But we started by bringing a little bit of a historical perspective on the subject. I think it's one of the most exciting subjects in feline medicine and in veterinary medicine in general, because we learned so much, especially particularly in the last 10 years. We have progressed a lot. We talk about kind of the pearls, the things that we knew, but also the upcoming stuff. We discuss a lot about pain behaviors, for example, the tools used for pain assessment in cats, and as well as the treatment, including the analgesic plan that we're going to discuss today. You can also watch several videos that are available on YouTube, including some of the local anesthetic techniques that we're going to talk about. And for this reason, I try to not focus much today on doses. And I know a lot of the people working in practice, they really want to know the doses that I use and etc. But this is all really well discussed, and somehow, hopefully, that's going to motivate you to go and look for this information directly within the article. It's fascinating because the article has been downloaded over 31,000 times. I'm recording the end of the May. So this is all exciting. And we also have a part that we talk about pain assessment, giving some focus to shelter animals and those that are fractious and cats that are also part of spay-neuter programs, for example. We discuss also the issue of opioid unavailability, or cases where we have opioid shortage, what we know about it and what we don't know about it, and what we can do in these situations. And we finalize with a bit of a perspective about the future of feline pain management in cats. So again, this is about acute and not chronic pain management. So all the discussion, you should be taking consideration that. I'm going to start with this sentence that was actually taken from the guidelines, because I think it's going to be talking a lot about the concept of what we're bringing today. So we discussed that pain management is not only about giving an analgesic drug. So a lot of the focus in the recent years was like, what's the drug that you use, what dose that you give, what's the frequency or route of administration. And we have moved from this concept of giving a protocol of something to a plan, because an analgesic plan is going to take in consideration the protocol, but also, as we say in the sentence, the emotional needs of the cat. We also use feline-friendly handling techniques and all that to take in consideration the cat as a species, a unique species that we all love usually. That's why we're here, and with respect and empathy too. So a lot of the nursing care, a lot of prevention of stress, vomiting, anxiety, and this is what I would like to stress today. So I think that was a good starting point. Before we go on and talk exactly and specifically about the analgesic plan itself, I would like to start by building how we get there. Some general considerations before we talk about it, then it would be drug metabolism and elimination, how this is different in cats compared to other species. And this will have a significant impact on the drug choices, doses that you're going to be using, routes of administrations, and intervals of administrations, actually. So if we think about the drugs that can be metabolized by conjugation, oxidation, or unchanged, we could think about these three different groups. So if we start with the first one, the drugs that are metabolized by conjugation, and that will include the group that is going to go through glucuronidation, we know that these drugs will be excreted more slowly in cats than in dogs or even humans, for example. And for us, talking about analgesia, of course, you would know about that we should never give paracetamol as part of this issue. But for others, it's also to think a little bit about carprofen, ketoprofen, and even morphine. So cats, for example, they tend to eliminate morphine at similar rates to dogs. However, they will actually produce lower concentrations of the morphine-3 glucuronidase. So this is actually the active metabolite of morphine in humans and in other species. So it doesn't mean that cats you should never give morphine to cats, but it means that they will be producing the active metabolite at lower rates and not at the same quantities and, of course, concentrations. It doesn't mean that morphine doesn't work again in cats, and because of the nausea and the vomiting that it produces, I usually stay away and I prefer to use other opioid analgesics, such as methadone or buprenorphine. The second group is the group that we talk about drugs that usually primarily undergo oxidation that are often eliminated, in this case, the opposite, more rapidly in cats than in dogs. And for us, it would be important to know meloxicam, piroxicam, actually buprenorphine, and meperidine as well, or pethidine in the UK. So, which they will just be usually metabolized faster in cats than dogs again. That doesn't mean that none of these drugs will never cause any adverse effects. Doesn't mean that meloxicam is safer in cats than in dogs. Particularly in terms of non-steroidals, we want to stick to safety above everything else. So whatever there is a contraindication for a non-steroidal, you will stay away from them, more objectively speaking. And finally, there are some drugs that are metabolized unchanged here, that are or either into urine, for example, or the bile, such as gabapentin, which is a drug that is being widely used these days. And in this case, they usually will have similar elimination half-lives in dogs and in cats. So this is just to start thinking on how my feline drug metabolism excretion will impact our dosage regimens in this case. Another consideration is the presence of comorbidities that must be considered in the treatment of pain. I think the guidelines, we took a little bit of a highlight into chronic kidney disease, as we have to consider that as many as 40% of cats over 10 years of age have chronic kidney disease or CKD. So it's unavoidable that in these patients, doses and dosing intervals that will require some adjustment, and this will often be based on clinical experience and also the patient's assessment and analgesic needs, for example. What we have to understand is that the effects of drugs in these cats may not be always predictable. And a classic example, the first one, is the metabolism of ketamine by the liver in cats versus dogs. So cats, they will only usually metabolize ketamine into an active metabolic called norketamine, which is still active, as I mentioned, which is a bit different than dogs. But what is important in cats is that norketamine and ketamine will be excreted by the kidneys in their active forms often, which means that if you don't have good kidney function, these drugs may accumulate and, for example, give some adverse effects, such as prolonged recovery in cats with CKD or those that are with acute renal failure in terms of due to urethral obstruction. This is just something to keep in mind. Another major discussion that we've had in the past 10 years that you might have heard of is the use of non-steroidals in cats with IRIS-1 or IRIS-2 stable kidney disease. And this has been discussed in quite detail in this capsule review, if you haven't had a chance to see it, which is like summarizes the evidence that we have in terms of using, for example, robenacoxib or meloxicam in cats with CKD. So when, how, what are the tricks, what are the doses? And usually we stick about to the minimum effective doses, but this is a lot related to chronic pain. But these cats, they will undergo some surgery or they might require the non-steroidal administration in the perioperative setting too. So we should be able to take all of that in consideration and see if these patients could be potentially eligible to give one single dose, for example, of non-steroidals. For some of these patients that are IRIS 1 and 2 that are very stable in terms of their disease, when they're normal volemic, when they're eating and drinking, sometimes I have recommended to, for example, the dentistry service that I worked with, to give one single low dose of non-steroidals after multiple dental extractions, for example. And of course, I'm giving fluids during the surgery and also controlling blood pressure, or trying to, monitoring blood pressure, I should say. And the third case is the use of gabapentin. So I would like to explore a little bit more gabapentin on the next slide. We published the guidelines and we said something like, watch out for patients with chronic kidney disease because gabapentin is excreted by the kidneys. And we suspect that maybe the concentrations will be increased and the elimination will be prolonged. And fascinating, like some of these authors, they just published very recently this article exactly showing that assessing the serum concentrations of gabapentin in cats, in healthy cats, but also with those with CKD. And they basically ran a pharmacokinetic study to show that the cats with CKD, they had a higher serum plasma concentrations of gabapentin at 3 and 8 hours post-op. And there was also a correlation with creatinine levels in these patients when compared with controls, showing that indeed we have to adjust and perhaps reduce the doses of gabapentin in cats with CKD. But again, it's also taking consideration your outcomes. What are you looking at when giving these drugs to these cats? So now we can finally start talking about building an analgesic plan itself. So each cat is unique, and I think what we try to highlight during the guidelines is that the approach should also be individualized. So what's the case? What's the type of noxious stimulation? How often? For how long? And this is all we're going to be discussing right now. So in this part of the guidelines, we talk a lot about the principles of acute pain management. And these are the first three ones that are the basis for a lot of what we do. So the first one, preventive analgesia, always combined with multimodal analgesia. And again, as I mentioned before, we no longer rely only on the pharmacological therapy. We're also going to try to incorporate some non-pharma therapy. And this is what I would like. But let's take a look at what that means. The first one, preventive analgesia, it's kind of the terminology that replaced what we used to call preemptive analgesia. Preemptive analgesia used to refer to the administration of analgesics prior to surgery, prior to the tissue insult or tissue damage. And it was believed that it was the best way of preventing pain postoperatively. What we turn into this concept is more like preventive analgesia, which is preemptive analgesia is part of, but now it refers to all types of perioperative techniques and efforts to decrease postoperative pain. For example, giving non-steroidals at the end of the procedure, or giving another dose of opioid postoperatively. This is, or early postoperative. So this is all preventive analgesia. And analgesics are now administered at any time and for any duration needed for pain relief. So this is something that we're going to be basing, obviously, but a lot is still be done using the concept of preemptive analgesia in terms of anesthesia. The second thing is the multimodal analgesia, which is the administration of two, as you can see there in this diagram, the two or more analgesics that they have different mechanisms of action. So there are classes of analgesia with different modes of action that will be interfering in what we call the nociceptive pathway in different forms. One will act in the periphery, another one in the spinal cord, another one maybe in the central. And what we're trying to achieve with these drug combinations is a synergistic effect that will allow us to use lower doses of each class, and consequently, we're going to also try to prevent treatment-induced adverse effects in general. So something that we also have to consider is that multimodal analgesia is not only about drugs, it's also about the co-therapy, for example, the non-pharma therapies. A little bit of a story that I've never told you about this figure there. I was checking my Facebook the other day, and I saw this figure, like it popped up in my thing, and it was like, wow, that's a figure that I created for a book chapter in my book, but it was saying the Johnson diagram. So I don't know who the Johnson is, but I just want to tell you that I did that figure for my book. So if you see it around, thank you, Johnson. I knew the person was not called Johnson, by the way, but it was just saying that this was the Johnson diagram. But this is just simply a figure that we had in my book, in the book that we wrote together with Dr. Robertson and Dr. Taylor. And well, let's go back to what is important here. So, and the first line of analgesics that we're also going to be thinking is using non-steroidals, opioids, and local anesthetics. In the second line of analgesics, and this is my train of thought when I'm on clinics, we're going to be thinking about what we call adjuvant analgesics. So over my years teaching veterinary anesthesia and pain management, I was creating some materials for my students, and I came up with this, what I thought it could be a simple way of thinking when you start building now exactly at this point your analgesic protocol as part of the analgesic plan. So the first thing would be to ask yourself, is there a local anesthetic block that I can use? And if we looked at 10, 15 years ago, we would be like thinking about just epidurals maybe, or incisional anesthesia. But now we have many blocks that can be very easy to use, and like they're very day one skills. And we're going to be talking about that. So we have many blocks that can be used for castration or ovarian hysterectomy, for example. The second question is to think about not if I'm going to use or not an opioid. It's usually what's the opioid of preference. So how long do my patient need an opioid for? What are the doses and the intervals and the routes of administration that I'm going to be using? The third question is most likely, especially in terms of surgical pain, are there any contraindications for non-steroidals? Surgery probably means inflammation, so they should be considered as part of our multimodal approach. And the fourth one involves, is there a need for adjuvant analgesics? And we're going to discuss each of these questions now separately. So for the local anesthetic blocks, I think the guidelines present to you not only the three techniques that I'm describing with some videos, but also the idea of using dental blocks that are very easy to be performed. And if you don't know it, you can always watch the videos and learn with a colleague, for example. They're not complicated at all. And they can also be considered to be day one skills. We have significant evidence now that these blocks, they provide early postoperative analgesia. We know the doses that are safe now for these patients and that are actually effective, especially as part of a multimodal approach. And all these techniques that are usually provided with the cat under general anesthesia. They're also going to be able to reduce your anesthetic requirements normally. And in some cases, they might blunt what we call sympathetic responses to surgery. So, for example, in the case of an intratesticular block, usually when you have it on board, you avoid those spikes in heart rate and blood pressure during the procedure. A lot of people, they tend to confound that my patient is under general anesthesia. I don't need to provide this block. That's a concept that is incorrect. Everything that we're doing with a patient under general anesthesia is simply blocking the perception of pain. Once that patient wakes up and is extubated, he's definitely going to feel all the noxious stimulus that was produced during surgery. unless if we treat with proper analgesia. And that's the idea of providing these very simple blocks. So I invite you to check it out, the guidelines again, watch these videos and know more about these 3 very simple techniques. The videos are self-explanatory and one could be able to apply that in practice after. You can also consult this capsule review article that is open access, so it's free. So it was published in the journal of Small Animal Practice, again talking about what actually the evidence is for these blocks. Opioid analgesics, that's also the question, which one, when, what routes, and when I can use one versus the other. For me, is not that complicated. I usually these days, whatever I can, I avoid using morphine or hydromorphone because there's still perioperative vomiting involved with these drugs. And I just think that for many years we took them very lightly, and that's not a positive emotion. That's not something that we should be not caring about. So I usually try to stick with these 3 opioids that you see there, and maybe fentanyl, remifentanil, when infusions are required. But normally, I usually like using methadone for cases that I know it's going to be moderate to severe pain involved, especially, for example, when other drugs might be contraindicated, such as nonsteroidals, or when local anesthetic blocks are not available. I like using buprenorphine, especially from mild to moderate pain, particularly in combination with local anesthetics and nonsteroidals. We have significant evidence now that buprenorphine, when combined with a local anesthetic and nonsteroidals, provide appropriate analgesia for several procedures, including dental extractions, ovarian hysterectomy, and castration. And finally, I stick to butorphanol purely for sedation or procedures that are very minimally invasive. And this is usually how I take it. The guidelines also talk about the cases of opioid shortage or when opioids are not available, which is unfortunately the case for many of our colleagues in different countries, that veterinarians do not have access to these drugs, not even in inhalant anesthetics, for example. And then we can bring it up into the discussion, the concepts of opioid-free or opioid-sparing. Opioid-free is basically a technique that you're going to be completely abolishing the use of opioids, either because you have an option or not. But it doesn't rely on analgesia of that patient based on opioids. So you're usually going to have to use local anesthetic techniques, non-steroidals, in combination, for example, with alpha-2 agonists such as dexmedetomidine, even still xylazine in some countries, and finally also the use of ketamine in some cases. Very recent research in our laboratory, we have shown that this is not easy to be achieved in cats undergoing ovarian hysterectomy. This could be the case for kittens, as we have recent evidence, but in adult cats undergoing ovarian hysterectomy, we could not completely eliminate the need for opioids in cats undergoing ovarian hysterectomy using multimodal analgesia with local anesthetics and nonsteroidals, but without opioids. Opioid sparing is a much more reasonable concept that minimizes the use of opioids, perhaps with just a single injection. And also recent research in our laboratory, it has shown that this is possible now. As I mentioned before, with one single dose of buprenorphine in this study that we published, in combination with nonsteroidals and a local anesthetic technique such as the intraperitoneal anesthesia, we were able to eliminate the need for further administration of opioids in the postoperative period. Nonsteroidals, as I mentioned before, when we have surgery, we have tissue damage, most likely we're going to have some level or some degree of inflammation. And that's when nonsteroidals can be very interesting. However, the most important thing is to respect the contraindications. And there's not much black and a gray zone there. It's usually black and white. No, it's not, is it? So in this case, I would say that if the patient is anorexic, if the patient has vomiting or diarrhea, if the patient is hypovolemic or with severe dehydration, non-steroidals are contraindicated. We could talk also about unstable renal disease. We could also talk about perhaps real liver disease, that the patient would not be able to metabolize non-steroidals, or the combination with corticosteroids. Those are the real contraindications that we should be really cautious. But there are several examples, especially those patients that are hypovolemic, those patients that are dehydrated, that we could provide fluids, for example, and consider a dose of non-steroidals postoperatively. One thing that we cannot have anymore in our profession is just fear, because of fear of non-steroidals induce adverse effects. And what I'm trying to say is that it is scary. The adverse effects can be serious with these drugs, but I also think there's room for improvement and for understanding when or when not to use these drugs. And which one? Usually in veterinary medicine, we have several studies showing that one single dose of non-steroidals, pretty much they will have similar efficacy. However, the two contemporary non-steroidals that we have more and more knowledge that can be administered for more than 1 day are meloxicam and robenacoxib. There are several studies using 1, 2, or even a 5-day dose planned for these two non-steroidals with efficacy and also safety. And I must say that in terms of safety, the studies that have been published with robenacoxib are quite positive. Again, it doesn't mean that these non-steroidals can be used without responsibility. Whatever there is a contraindication, none of these drugs should be used. How about adjuvant analgesics? Well, usually now we're talking about drugs that are not standalone analgesics that we should always be considered as part of the multimodal analgesic plan. The first one, dexmedetomidine, you could have sedation, you could reduce inhalant anesthetic requirements, but you can also have muscle relaxation and some analgesia, especially visceral analgesia. And dexmedetomidine, for example, or medetomidine can be used as part of pre-medication again. Ketamine infusions are often used to prevent or treat central sensitization. If you're not familiar with these concepts, there's a very nice table in the guidelines providing a glossary of what those terms mean, and you could look it up. The only thing is that using ketamine, usually you're restricted to the hospital. You're going to be having to use infusions because the drug is rapidly distributed and excreted. A lot of people also talk about tramadol. Tramadol, there are two things here. There are many countries, including South America, that you can use tramadol, the injectable formulation, and it's quite actually widely used there as part of pre-medication in combination with a sedative or tranquilizer. In North America and many countries in Europe, tramadol is only available in its oral form. And that becomes a problem if you have it to give orally. Differently than dogs, cats, they are able to produce the tramadol's metabolite, O-desmethyltramadol, that has been shown to have some significant analgesia in other species. However, the difficult thing is how to peel a cat with tramadol. That can become a deal breaker. And finally, gabapentin. We talked about gabapentin. We will talk about gabapentin in terms of the reducing anxiety, but also have you thought about using gabapentin for pain management? So in some cases, let me go back here. In some cases, gabapentin has been used in one study in our laboratory that showed some promising effects that we could have some analgesia related to the acute perioperative setting. And I'm going to talk about that in a second. Well, I gave all the drugs and the groups, the classes of analgesics, but how do we actually go into terms in choosing the analgesic protocol? This table, also from the guidelines, we'll talk about the concepts that, credit to Brad Simon, we call this TELS for pain management using specific examples. So, and these concepts, they will help you determine the dose, the frequency, the type, and the route of administration for analgesics. So the TELS concept talk about the type of noxious stimulation, the expected duration of this stimulus, the location also on the patient, if it's out or inpatient, and finally the severity of noxious stimulus, like mild, moderate, or severe. And then it helps you deciding with the drugs that I presented how you would approach that patient. And of course, pain assessment would be the best way, and we're going to talk about it in determining the protocol, and we're going to talk about it in a second. Again, I think we talked about, the first considerations, general considerations. We moved on to the analgesic protocol itself, talking a bit more of the drugs. We talked about principles, preventive, multimodal, combination of pharma and non-pharma. We talked about the 4 questions in pain management. And now I would like to approach that this is about more than the analgesic drugs themselves. Let's talk about these 5 concepts that are in that circle right there now that I find crucial as well to improve the hospital experience, to improve perioperative pain management and its setting. You're probably tired of listening to anxiety and stress during transportation and the use of gabapentin. But I would like to just stress here that in a recent article that I published as a review article with Dr. Brad Simon in the Journal of Feline Medicine and Surgery about procedural sedation and analgesia, we discussed the concept now that people are not more calling this in cats, that the pre-medication, as much as the pre-anesthetic and the pre-assessment, it starts in the home environment. And I'm not saying that every cat in this planet should be getting a dose of gabapentin before transportation. But for some of these cats, this can be produce a major difference. And also the experience that the owner will have bringing that cat. And that can determine in a life term if the owner will be keen to bringing this cat for annual rechecks or so forth than anything else. So I think as part of this pre-medication starts at home, we could be using the doses that have been published in the literature. And there is now being a recent study published in JAVMA that was actually using up to 200 milligrams of gabapentin per cat. So we're actually using one of the adverse effects of gabapentin, such as sedation, to actually benefit the cat. And we're now learning more and more what the gabapentin will actually do in terms of blood work, echocardiography, and so forth. So this is always still a learning process, but so far, nothing has come up that we should not be using these drugs in appropriate cases. And again, I just wanted to bring it up that maybe when we're using gabapentin, we might get some extra benefits by providing some acute perioperative pain management. This has been a subject of controversy in humans. There has been a recent meta-analysis and systematic review stating that gabapentinoids, such as gabapentin or pregabalin, should not be used for acute perioperative pain management because they don't provide analgesia. But this is all in a different context. How about if we use as part of multimodal analgesia and so forth? And this study performed in our laboratory in 2017, we showed that there was maybe a promising effect that should be further investigated in terms of how gabapentin could maybe, just maybe, have a role in perioperative pain management. And again, if I have to peel a cat with gabapentin versus tramadol, I would definitely myself choose to go for gabapentin. So this is perhaps in the mix. Antiemetics, I said that we take it so lightly, vomiting and nausea in our patients. It's just like, oh, okay, it happened again. But I want to talk specifically more about meropenem. and less about ondansetron because I have more experience with these drugs that I have used quite often in the perioperative setting. Basically, maropitant is a neurokinin-1 receptor antagonist that blocks substance speed. There was a lot of discussion if this drug was also analgesic. I do not consider maropitant to have what we call clinically relevant or to produce clinically relevant analgesia. If there's something there, that's great. I consider that to be a bonus. But I think it's really important to reduce nausea and vomiting in our cats in the perioperative setting as much as we can. So it's one of the things that it also contributes to patient comfort. There has been pretty solid data and information that it reduces vomiting. Looks that it doesn't reduce much nausea, but if it reduces vomiting and discomfort after opioid administration, I think this is already a positive thing. For those countries that we have available veterinary approved products, such as methadone and buprenorphine, I would stick to already these two opioids instead of hydromorphone or morphine that can produce vomiting. There's also some literature using maropitant to reduce vomiting in cats with CKD with positive results. And there are some studies, different studies using the clinical use, and this is maybe off-label, I must say, but also showing that there's reduced vomiting, there's some improved recovery, and in dogs, for example, there's pretty good evidence that improves appetite, and I don't know why it wouldn't happen in cats as well. You could have the approach of giving the drug subcutaneously, as it is in the label, to my knowledge, before opioid administration, but also to give it orally, either a couple of hours before the surgery or in the home environment by the owner, giving in preparation to surgery the next day. Nursing care that sometimes we get overlooked. Again, it's all based on drugs, but how about nursing care? And I could not stress enough the importance of veterinary nurses or technicians. I could not provide the same level of nursing care that I usually work with or have from the nurses and technicians that work with me. So it's so fundamental to have them as part of the team. And also look into our patients in a very different context, you know, when they're very fragile, post-operative, with all the respect, empathy, and care that they deserve. This should be considering patient positioning, especially those that, as you can see, after severe trauma on the bottom right, that will require significant monitoring, but also be taking care of patient positioning, eye lubrication, for example. This should also be taking into consideration the nutritional aspects and the needs of that patient. We should be looking to these patients undergoing surgery to be eating quite quickly if they're allowed to after surgery, to have minimal impact on their microbiota, but also avoiding some of the drug effects such as constipation, and also thinking about fluid therapy, no less, no more, but also coming up with an appropriate fluid therapy for each of our cats. And finally, bladder care as well, especially those cats with urinary issues, undergoing urinary surgery, making sure that this is all taken care of, but also that making sure that the location, the site that the patient is dry, is taken care of, and also taking respect the species. You can see in the top right figure, performing a physical examination in that patient using feline-friendly handling techniques. We can also incorporate non-pharmacological therapy in these cases. I could have, or I could give the best analgesic in the planet for a cat, but unless if I go with a wound, but unless if I do a proper wound care, that doesn't gonna mean much for that cat. So this is also important to highlight and to stress that as much as it is important to give analgesics, for example, it is also important the perioperative care in terms of your surgical techniques and how patient management in general. So I think the wound care is a great example for that. And talking about wound, it comes into our mind bandaging, that so many cats require bandage. There are a couple of classic studies showing that cortisol concentrations and they can be as much as increased after a cat that is anesthetized and put on a bandage that a cat that was anesthetized had surgery and didn't have a bandage. So it's just to highlight how bandages can be annoying to cats, especially when they're not properly performed. So you have to, and we have to think about that. If that bandage is appropriate, is it comfortable? How long do we need that bandage for? Is just for our comfort or actually needed for the cat? And finally, trying to think about considerations in terms of cold therapy to reduce inflammation and edema, especially when it's localized, avoiding direct tissue damage with the ice therapy, for example. But while the cat is waking up from anesthesia, could we perhaps try to perform a 5-minute ice therapy, cold therapy, while the cat is waking up, for example, after surgery with quite some inflammation and edema? In terms of the environment, in terms of the clinic, I know not all of you will have followed the clinic accreditation or the AAFP practice program and etc. But the idea is that even if you don't have this accreditation and all that, a lot of the things that are described in these programs can be applied on your daily routine in your clinic. And you can see lots of examples there, especially separating cats from dogs, providing a comfort bed. And you can have, for example, these very expensive card boxes to provide a place for the cat to somewhere to hide, to perch, and to hang out during the hospitalization. It's all about the empathy again and how we approach them, giving them time to adjust and to have an interaction with us. So this is all about also not giving the drug, but improving the hospital experience, as you can see in many examples in these figures. Finally, the environment and home meds. This is maybe very obvious for us, but if we don't tell that to the owner or the caregiver, this might not be evident. So thinking about a place that is comfortable and quiet for the cat, that it has its own sleeping, resting area and a place to hide, and also easy access to resources such as food, water, and the litter box. And the caregiver might not think about it unless if we tell them. And this is, again, great to have veterinary nurses involved as part of the veterinary health team. We also have to think in how we're going to prescribe drugs, and palatability becomes crucial in the business. Imagine giving tramadol 3 times a day, what you would do with the relationship, the human-cat bond that these people, that we would break by doing so. People is scratching, scruffing cats and all that. So we have to think about means of getting those drugs in with minimal trauma. And I would like to stress that maybe you don't need to build up a cat castle as a colleague of mine, she does with her cats. But this is just to show you that they need their own place, and it's as part of the road to recovery. Before I go here, I'd like to briefly talk quickly about a bright future for feline pain management. I would like to be optimistic about this subject. What I've seen over the past 5 years maybe, or even a bit more, is a completely switch from a very feline topic base, for example, feline nutrition, feline pain management, to a more feline health in first place. And this is not only from veterinary associations or organizations, but also a switch from the industry as well. We're now looking at the cat as we did today in terms of analgesic plant, in terms of feline health. We're now really understanding their behaviors. We're really understanding their needs and going from there. We're also trying to avoid, as I mentioned 10 times today, the fear and stress and anxiety. But also we're looking more and more into characterizing feline behaviors related to many things. So we've done some work with characterizing feline dental pain or oral pain cats. We're doing some extensive work now in the laboratory, understanding kitten behaviors. Imagine watching kitten behaviors all day to understand their knowledge. Can we call this a PhD or not? And we're now finally getting to the point that we can automate some feline pain assessment tools like the feline Graham scale using artificial intelligence, but also using machine learning. So I don't think we're far from the day that we're going to be taking a picture of a cat, and hopefully that phone application will tell you with precision, specificity, and so forth, accuracy, if your cat is painful or not. So I think that could be a game changer also for feline health and feline welfare, right? And we have now the advent almost every year or a couple of years now for drugs for feline pain management, such as the anticlonal antibodies for chronic pain. But also I would like to just bring it up that recently the Food, Drug and Administration approved transdermal buprenorphine for the control of post-surgical pain in cats. So it's very exciting to have a single application of a medication that is going to have a long-acting effect for an opioid. And maybe the labels, again, might look weird in terms of labels, and as we know, but this is exciting. This is a step forward that we have more and more options in our arsenal. We talked a lot about treatment building the analgesic protocol. One fundamental thing about the analgesic plan is also making sure that our treatments are working. So pain assessment must be part of that. So I invite you also to visit the Feline Graham Scale website to learn more about it, or download the application for both iOS, Android, Spanish, French, and English. My final remarks here. I feel so overwhelmed sometimes with the amount of information that we have in the literature now. So many articles, so many things to read. Everybody's talking about it, that we also feel that sometimes we're a bit behind there. And for more that I do this for living feline pain management, sometimes it's really tough to catch up. But what I would like to also tell people is that when we go back to the basics and we keep it simple and practical, as I mentioned, opioids, local anesthetic blocks, non-steroidals, I think we can do a lot with acute pain management in that regard. And perhaps in some cases, there will be some the benefit of adding an adjuvant analgesic. But most important, all the non-pharma things that we discussed is really reachable. And I think we can do a lot going with cost-effective, simple, and practical techniques. And that includes TLC. That is free, right? So it was great to talk again to the ISFM community. Thanks for watching. Thanks for being here and for your attention. And I really hope to see everyone on the road as soon as I can get out of Hong Kong and travel again. So I hope you enjoyed this webinar. Check it out, the guidelines. I hope you like it, and talk soon.
Thank you so much, Dr. Deagle, for an absolutely fantastic presentation. So much useful information, and I absolutely love the emphasis on the holistic approach. And I think it is often easy to get caught up in the drugs and what dose of this, what dose of that. Yeah, it's not all about the drugs. So it's really important, and I really like that that's all been included in your presentation and in the guidelines as well. So thank you ever so much for that. We do have some questions, so are you happy to go through some?
Absolutely. Hello, everyone. Thanks, Sarah, and thanks everyone for watching.
Brilliant. Yes, we've got lots of people attending, watching from all over the world. So it's an absolutely fantastic audience today. So that's brilliant. Okay, so we had some early questions come in, so I will start with those. There was a nice question about cats with decreased intestinal motility, so maybe megacolon or constipation. What would you think about pain in those patients? What sort of drugs would you be wanting to use, or anything else that you might want to consider alongside that?
That's a great point. This is a type of medical pain that many practitioners will be facing. There is some concern about using opioids because they can reduce intestinal motility, as you mentioned, especially in these cats with megacolon and so forth. But we also have to think that, in my opinion, it's a much bigger effect to leave them in pain, because pain will also cause sympathetic stimulation and also reduce intestinal motility, or gastrointestinal motility in this case. So for me, I think I'm not an internist for sure, but we should be treating these cats with their appropriate medical treatment. Fluids, it's a huge thing for increasing intestinal motility, for example, and we got to keep them comfortable to avoid these increases in sympathetic stimulation. So for me, it is the type of case that is difficult to manage in the home environment, that we need to have, we need some type of like hospitalization for a while to provide fluids, to provide medical treatment, and also in this case, put these cats on opioids. So I think in this case, opioids, even if there might be some controversy about reducing the intestinal motility, they're crucial in keeping these cats comfortable until you get an enema and so forth.
Excellent. Thank you very much. Brilliant. Next question. You talked about gabapentin, and I know you said we might be bored of it, but I don't think we are. We're all still talking about gabapentin, so it's still a very hot topic. But you particularly talked about it, using it in cats with CKD, and the question is really whether, when we have cats with CKD and we want to use gabapentin, when we talk about reducing doses, do you relate that to the iris stage, or is there something else that would make you reduce the dose down for that individual cat?
I don't think we know the answer for that, actually, because what we know right now, we suspected that concentrations of gabapentin would be increased in cats with CKD, and that's great. We know by now, by this recent article by Dr. Quimby and co-authors, that yes, in fact, when you have CKD, these concentrations will be increased. The drug is taking longer to be excreted, and etc. And we should be expecting a prolonged clinical effect. However, we don't know exactly how we should be tackling these doses or tailoring these doses according to the individuals. Should it be according to the iris stage, or just what I would say and what I would suspect, clinical judgment, actually? So for me, if I have a cat that I would be treating with 10 milligrams per kilo, I'm going to cut it back to maybe 5 milligrams per kilo. And instead of giving 3 times a day, I'm going to try at 2 times a day, and so forth, and see how the cat reacts. And this is my home experience with my own cat, that, I used to give gabapentin for him a little while ago, and he would be sedated, and he completely lost his mojo for a while when he was on gabapentin. So we definitely need to adjust the dosage regimens, but according to the patient and according to the client will tell us.
Excellent. Yeah, I think that's a really good point, isn't it? Is that all the doses, particularly for things like gabapentin, there is a recommended dose, but we have to look at the individual cat and get the feedback from the caregiver as to the effect that it's had as well, don't we? So brilliant. Fantastic. Thank you very much. There's another good question, actually, which I thought was a very good one. And it's about cats that have cognitive dysfunction. So maybe some of the older cats that are starting to have this sort of mental decline. Do you have any particular recommendations, thinking particularly that maybe some analgesic drugs may have an effect on their mental state? Is there anything that we might want to consider in those patients that already have an altered mental state?
Right. That's a great one. Another very hot topic that we very poorly understood, and we don't know much about exactly the correlations between pain and cognitive dysfunction. I would suspect that there is a component of these cats, and I have one at home that is turning 20 this year.
Wow.
He's becoming pretty wild overnight, and he's just like really agitated. And he's being treated some analgesics, but I'm gonna switch him to this new treatment with monoclonal antibodies and see how it's gonna play a role on him. If it's going to improve his clinical signs. But my point is that we should definitely try to rule out if these cats with cognitive dysfunction, they are also having pain concomitantly, and so that we could potentially address that, and perhaps we would help them being less anxious and agitated, that because we know very little about this thing. So I really believe that, yes, with all the advances in knowledge in terms of osteoarthritis, in terms of pain assessment treatment, I think we can do much better on that end. And if that's one of the causes of chronic pain in these individuals, that I hope that this would also improve their cognitive dysfunction.
Brilliant, thank you. Another area for more research, isn't it? I think so. But we'll get there.
Exactly. Yes.
Brilliant. Okay, I've got two more questions, I think, if we've got time. The next one is about urinary obstructions, obviously mainly male cats. But let's say, for example, we've got a male cat with a urinary obstruction for whatever reason, and we've got a increased urea creatinine, but due to the obstruction rather than an underlying renal disease. Any protocols for dealing with, obviously, the acute pain of the obstruction, but also the fact that we're going to have to do a procedure which is going to be pretty uncomfortable for the cat as well?
I think it's pretty safe that you can start, of course, giving your fluids beforehand, before even unblocking this cat. These cats, they're usually treated really well with opioids, either methadone or buprenorphine. And there's somehow like it's becoming more and more popular now. And I think we mentioned that in the guidelines as well, the use of what we call the sacrococcygeal epidural. And in that case, it's just basically using lidocaine as if you would be doing horses and cows, if you remember, pumping up the tail of the animal to find the best spot for your epidural. So this would be a similar procedure, doing the sacrococcygeal epidural with lidocaine at 0.1 mL per kilo. Always remember the epidurals have to be completely sterile. And a combination with the local anesthetic and the opioid, that should provide appropriate analgesia for these procedures, even if you have to go into surgery. In terms, I would definitely consider non-steroidals only when my patient is normal volemic, again, eating and drinking normally, and the worst has passed. So this would be probably my approach right now. If you don't know how to do the sacrococcygeal epidurals with lidocaine, you would definitely going to have to rely on the opioids in terms of analgesia.
Brilliant. Thank you ever so much. I'm just going to ask one last question. This is actually a question we get asked quite a lot here at ISFM, particularly from nurses and technicians, and that's about post-op analgesia for routine procedures like neutering, and I'm thinking particularly males and females here. In the UK particularly, it is quite common for females to go home with some oral medication, but not males, and some people are concerned by that. Obviously, it depends what else they have whilst they're in the clinic. But do you have any sort of standard recommendations on what we should be doing, regardless of what age they're new to that as well?
Yeah, that's a very relevant question, right? Clinically important as well. So I think for me, and I'm going to go ahead and I know people, they want to treat pain. They're very, it's great that we're thinking about this right now in terms of feline welfare. But I'm going to go straight to in terms of the evidence based on what we have. We have spayed over 500 cats in the research setting, in terms of clinical trials in my lab here. And what we know about it is that if you use a dose of opioids, either buprenorphine, for example, or methadone, in combination with a dose of a non-steroidal, it could be robenacoxib, meloxicam, for example, plus a local anesthetic block involving, for example, the intraperitoneal technique that is quite well explained in the guidelines, and there's a video of it. we know that 99% of these cats, they do not require any analgesics postoperatively. In terms of, I'm talking about spaying these cats, so viral hysterectomy. So, and we evaluate pain 24 hours later, and we give an extra dose of the non-steroidal, and they go home, and that's it. They're comfortable. They don't need any other analgesic administration. In terms of the male cats, I would have a similar approach. I would do an intratesticular block. I would give a dose of non-steroidals and repeat it 24 hours later, and also combine an opioid in my premedication or as part of my protocol. And I think by doing that, by doing this, using this, the first line of analgesics, opioids, non-steroids, and local anesthetics, I'm pretty sure you're doing a great job in terms of analgesic plan.
Brilliant. Thank you ever so much. So it is a common question that we get. And like you say, it's looking at the evidence base as well, isn't it? So I think, yeah, blocks definitely the way to go. And as you said, there's lots of information in the guidelines as well as a video. So for people who are not sure about those or a little bit uncertain, then that's a good place to learn and give it a go. I'm gonna stop the questions there because I appreciate that you do have a flight to catch as well. So thank you ever so much for your time. Absolutely brilliant presentation, and thank you so much for the additional time as well for the questions and answers. It's really nice of you, and we really appreciate your sharing your knowledge and your time. So thank you ever so much, Dr. Stiegel.
Thank you so much, Sarah. I'm heading to the airport, correct? And I see you, for those who are attending FECAVA, I'll see you soon. Thank you so much.
It's good to be back out there again, isn't it? So hopefully we'll all catch up in person one day. I also want to, brilliant. I just want to also thank everyone for joining us today. Hope you enjoyed the session. I will very shortly make this recording available. So if you want to come back and watch again, you can use the same link and it will be there as a video to watch. And we will also have the notes and the CPD certificate and the links to the guidelines, etc. That will all remain there as well. So you, if you don't have time now to visit those things or download them, then you can come back and do that later. Don't forget also to visit the Cat Care for Life website that I mentioned at the beginning. And of course, check out the acute pain guidelines for all that information, lots of information on doses as well. I know people have been asking about that. You should find all of that in there. And then, of course, the blocks as well that we discussed just a moment ago. Everything's in there and it's all free to access. The link is in the resources section in the webinar here. So no reason to just not click and have a look. Download it if you want to and have it available in your clinic. So thank you ever so much once again to Paolo and of course to everyone for joining and watching. And until our next webinar, goodbye everyone.